All right, guys. So welcome to our webinar this evening, What Causes Back Pain and Options for Treatment. So in today's world, we are doing this virtually. We would typically do this in person, but we have found that this works nicely for patients to be able to be at home with maybe their family. You can do it from the comfort there and not have to go anywhere. So we appreciate all of you that are joining us this evening. We are going to have Dr. Miller's going to do a presentation, and then we're going to follow that with a Q&A session with a patient that Dr. Miller has operated on. So what we're going to do is hold our questions to the end. And for those of you that are on the call, you can ask questions two ways, which I will also, when it's time for Q&A, I'll let you know. But there's a Q&A feature within Zoom that you can see. And then you can also text me questions, and I will put that up on the screen later. So, oh, Dr. Miller, you'll have to advance the next one. So today on our agenda, we're going to, of course, go over what causes back pain. What are some of the reasons that you might experience pain? And then what are some advances in minimally invasive surgery, especially those that Dr. Miller offers. And so he's going to review some of those advanced treatments that he offers for back pain, including spinal cord stimulation. Next slide. So our presenter, of course, is Dr. Peter Miller of Iredell NeuroSpine Center, and he went to the Medical University of South Carolina in Charleston and did his residency in Pittsburgh at the School of Medicine there, and he also did his fellowship. He is board certified in neurological surgery. In addition to having a clinic in Statesville, he has a clinic in Mooresville and Hickory, and he's going to tell you a little bit more about his team. So turn it over to you, Dr. Miller. Thank you.
All right. Thanks, Lee. I appreciate that. Welcome to everybody here. I can't see you all out there, but I appreciate you all checking in with us and being willing to watch this. We're actually broadcasting here from the Iredell NeuroSpine Center itself. And I just wanted to talk with you about back pain, which is a common problem, and then it kind of introduce you to some options of treatment that we have here. And then, as Lee mentioned, we'll be answering questions. I would say up front that, remember, I can't answer any specific person's questions about themselves. Like, let's say you say, look, I had this fusion, and what do you think can happen to me? Since we don't have your x-rays or those kind of things over this webinar, I can't really, answer specific questions, but I can certainly answer general questions you might have about options for treatment. We have a dedicated team here, and I'm fortunate in that it's rare for any surgeon to have this, but what you see in this picture here is our surgical team, and they are with us for every surgery. So how we do it, we go between two different hospitals, and the team is always with me. So we have the same people doing the operations we do over and over again. So we know I can stick my hand out, and my surgical coordinator, Eddie, can just, he knows what the next instrument is. So it makes it a lot safer for our patients. So in talking about back pain, we all know, I mean, you're here for a reason, and back pain is a common thing. 8 in 10 people experience a severe episode of back pain that may keep them out of work. It's the leading primary care complaint. So people who go into their family doctor, back pain is the leading reason why people go. 44 million visits per year or more, depending on what year you look at. Sorry, got a little. And about 34 million people per year spend one or more days in bed in a given year because of back pain. It keeps them out of work. It keeps them from doing what needs to be done in their life. And as we all know, low back pain prevalence, how often people get it, increases as we all get older. Now, one thing I want to stress to you, even though I'm a neurosurgeon and this is what I deal with, is back pain and surgery, those kind of things, the overwhelming majority of back conditions do not require surgery. So I want to stress that is that plenty of people can be treated for these episodes of back pain, and they don't need me in terms of needing a surgeon. Also wanted to talk to you about a couple myths of people think these things that are not correct. A lot of people think that strenuous jobs are riskier for your back than sedentary jobs where you sit around. Actually, if you have a strenuous job where you're frequently lifting or things like that, your back gets used to that and gets trained in the same way. Like I have patients who are professional athletes who their bodies are used to this and they're trained, their back muscles get used to it. The people who we see are actually, for the most part, people who are sedentary, meaning they sit around a lot there. And then, these are our weekend warriors, or somebody who goes out on the weekend and overdoes it and injures their back or has problems as a result of that. Another myth is that injury is the only cause of back pain. In fact, a lot of back pain just comes from wear and tear on our backs as we all get older. So that's also a cause of back pain. A lot of people believe that it's best. And in fact, when I was back in, say, medical school, we used to think that, you need to let them be in bed for a couple days with this kind of a problem. If you have back pain, we used to recommend 3 days of bed rest. Well, we found that that's actually wrong. It's actually better to get up and get moving. So the quicker you get moving, the better it's going to be for you. There's also risks of laying around. You can get things like blood clots or things like that. So we found that actually laying around a lot with back pain is actually not the best thing, and it's probably the worst thing for you. Another myth is that surgery is inevitable. In fact, surgery often is not needed. And here, I do everything possible to try to keep people from having surgery. We always explore every conservative option before we start thinking about surgery. And also another myth is that back surgery is dangerous and ineffective. I have people that come to me and say, I met somebody at church that had this operation and they've just, they had terrible results and it didn't work. And I mean, certainly there are people whose surgery does not help. There's no question of that. But by far, most people actually do very, very well with surgery. And one of the reasons is that we choose people to operate on that are people whom we can help. So when we're talking about back pain, there's two things, right? There's acute back pain that happens as, you go out, you do yard work or whatever, and you strain your back, or for whatever reason, it just starts up. Then there's chronic back pain, which is a back pain that's with you all the time for months at a time. Let me talk briefly about if you get an acute episode of back pain, what are some things you can do to help yourself? The big thing is, if you can, try to keep moving. Try to keep moving, because a lot of times you can work through this pain and the muscles, if they're having spasm, for instance, if you lay down, that can sometimes prolong how long your misery is because the muscles stay in spasm. So if you can keep moving, that's a big help. Try, if you can't, if you're like, look, I cannot get out of bed, try to stay in bed for a day at most. Try to do everything you can to get up and get moving along. Anti-inflammatories, over-the-counter ibuprofen, naproxen, those kind of medications can help greatly as long as it's, you don't have a reason that you can't take them. Those are often very helpful in the initial stages of back pain. I find some people do better with ice. Some people do better with heat. That's a thing to try out and see. Some people actually find that it's actually alternating heat with ice, like 30 minutes of one, 30 minutes of the other. The only thing I would caution you about is that if you're using a heating pad, be careful, because if you fall asleep, you can literally burn yourself. And nobody wants Walmart tattooed on their side because they've been using a Walmart heating pad. So just be careful about that. Now, after you get over the first stage of things and things seem to be getting better, walking is good. If you start walking, that helps stimulate your blood flow so that the muscles start recovering from this. You can ride an exercise bike, meaning one of the ones that's a stationary bike, not go out and ride your bike. You want to try to limit twisting, stooping, and bending right after you start getting better. Massage can be a great help during this time because that helps also stimulate blood flow to the muscles, and also chiropractic care. That can be a great help to people to get them moving after right after the start of episode of back pain. Finally, once you really start feeling like, okay, it's all calming down, things to start thinking about are stretching exercises that can help. Flexion and extension, sometimes bending forward, sometimes bending back can help. It depends on the cause of why you have your back pain, of what might help, but you can just kind of work through it yourself and figure out, oh yeah, stretching forward, that helps relieve that pain, or sometimes stretching backwards can help it. So the question is, in an episode of acute back pain, when should I call the doctor? When should I see a doctor about this? One of the big red flags we have is if you're having problems with your bowel or your bladder function, that's time to start, call your doctor. If you feel like you can't pee or you can't have a bowel movement, or the other way around, you're having either uncontrolled loss of bowel or bladder control, then those are emergencies, and you need to be seen right away with that. Other things that are not go to the ER type emergencies, but something that you probably need to see a doctor are, if you are having leg pain or leg numbness, that's a sign that maybe some of the nerves in the spine are getting irritated, as well leg weakness. For instance, if you're having falls or problems like that, that's a reason to start seeing, to go see the doctor about it, if you're having falls or weakness in your legs. Also, if you've tried the things we've already talked about and it's not working, then that's probably a reason you want to see the doctor. If what you've tried these preceding steps we talked about and it's not helping, then it's probably the next step would be to see your doctor. There are a lot of non-surgical treatments that are available for treating back pain and back problems. And in fact, I usually like to try to go through these with patients to see before we even think about surgery, because a lot of times we can get people through episodes of back pain or pain in the back that goes into the leg. We can get you through without needing surgery. And so physical therapy can be a great help. The anti-inflammatory medications, we talked about those, things like ibuprofen, those kind of medications. Chiropractic care can be a great help. We have now classes that we have for our patients who are having surgery, but we're going to be expanding this program to people with chronic back pain. Behavior modification. You can be trained to help limit the extent of the misery the back pain causes, and also trained in how to stay away from problems and get over back pain more quickly. And so those are options. Also, sometimes we can do injections that can help, and there's different types of injections that can be done to help with back pain. Now, when it comes to surgery for those patients who require surgery, I've got a couple things that kind of guide how I take care of patients needing surgery. The first thing is, if it ain't broke, don't fix it. We're treating you, not your MRI. So let's say somebody has a ruptured disc or something like that. If you're not having any problems from that, then there's no need to think about surgery at that point. So those are the things that I always think about is that if you don't need surgery, then we're not going to go down that road. Another thing that I think about is that I like people to keep as much of their original factory equipment as possible. And what that means is that, let's say you've got a problem that's clearly causing pain and it's the source of the pain, and we need to do surgery on that. We're not going to do other levels just in case. You need. I like people to. I'm kind of a minimalist about what needs to be done. We do what's necessary, but not more than what's necessary. So I don't view every patient as going, okay, well, let's just do this just in case. We do the surgery if it's necessary, and what's necessary, but not more than what's necessary. Finally, I am a big proponent of minimally invasive surgery. I've retooled my practice over the last few years now. Probably about 95% of my operations are minimally invasive. We'll talk what that means. In fact, I feel strongly enough about this. I actually teach minimally invasive surgery techniques to other surgeons. Of course, with the COVID, we haven't been able to have any of those classes, but that's how strongly I believe in minimally invasive surgery. So what is minimally invasive surgery? What it means is that we typically will do an operation through a tube rather than a traditional operation where people get a big incision and we strip the muscle off the bone in the back and do a big operation like that. We can do the same operation through a tube where we put a tube down that spreads the muscle apart without damaging it. So there's a lot of advantage to this. The patients, it causes less tissue damage. One of the things that gives people misery after surgery, for instance, is muscle pain because all muscles have been damaged. We limit the damage to the muscle by spreading the muscle apart rather than actually stripping it off the muscle, the bone. Because we do this, then it's less blood loss. A lot of our cases, we can do a major fusion and lose very little blood, maybe a tablespoon of blood or less sometimes with these kind of operations. There's also a decreased risk of infection because we're not doing a huge operation and damaging the tissue. It decreases the risk of infection, and also because we go through small incisions. We can now do fusions, for instance, through very small incisions, and that decreases the risk of infection. In the last, we looked at our numbers in the last more than 200 of these type of operations I've done, my infection rate's less than 1%. So that's been a real bonus for patients, is that it's easier on them, and it has less risk of side effects. Because we're doing a small operation and doing those minimal amounts of damage, then there's less need for narcotics, for pain medication, and it's also a shorter hospital stay. Most of our patients, even with major fusions, will go home the next day after their surgery, which that's good for you, because patients who, if you have a surgery, then it gets you back into your life and doing the things you need to do, whether it's work or being with your family, whatever you want to do, it gets you back quicker. So one of the main reasons why we can do these operations where it's a targeted operation right to the area, we have a CAT scanner. This is what our CAT scanner looks. We have a CAT scanner in the operating room that we use for minimally invasive surgery. This, let me see, just run this for you. This is just an animation of what it's like. We have the CAT scanner come in during the surgery, and we get a CAT scan right at the start of the operation. And then that shows us where everything is in 3D. Then there's a camera that you can see over here that sees where everything is. Then all our data in 3D comes up on a computer monitor, so I can see exactly where I'm going on the patient. Now, let's say I have to put screws in. We can put the screws in 3D, and I can see in 3D where it's going, so it makes it safer. Then we get a CAT scan at the end, so I don't even wake up the patient until we're sure everything's perfect. So you don't even leave the room until we're sure everything is perfect. Now, not everybody needs surgery. There's other options. There is also people who have maybe had operations or have conditions that give chronic pain. And so we talked earlier about acute back pain. Now I want to talk a little bit about chronic pain. When people have chronic pain, one of the things we ask is, are you able to perform the basic tasks around the house? Are you able to do your activities of daily living? Does your pain keep you from doing what you need to do in life? Does it affect your ability to work and be productive? Are you missing work because of your problem? Playing with your kids or your grandkids, does it keep you from doing that? Being sexually active, an important part of life, and if you're having a lot of back pain, then that can interfere with that. Your hobbies, gardening, arts, crafts, those kind of things, does the chronic pain keep you from doing that? Or outdoor activities, if you want to walk more, but I have this patient tell me this all the time. I used to walk 1 mile or 2 a day. Now I can't do anything because my pain is keeping me from doing that. And so for people with chronic pain, maybe all these things we've talked about, they've been through it. And so these are things some of you may out there that are watching maybe in this category where, look, I've tried the medications, I've tried physical therapy, I've tried TENS units, I've tried narcotics, maybe even a drug pump where it pumps the medication around your spine, or surgery or nerve blocks. And so there are other options apart from that. And this is one of the things I want to talk about next. So there's two types of procedures that are possible for patients, and it depends on what you have going on. There's a thing called the radiofrequency ablation. And what that means, ablation means it's just we're literally burning the nerves. And what that means is in patients who are candidates for this, instead of doing an injection where we're putting some medication, we can numb things up and put a needle down and then heat the tip of the area so that it burns tiny, tiny nerves that go to the joints of your spine. And that can be often a great help for people who have back pain. The second thing is spinal cord stimulation. And that's a thing that's been a very exciting advance in taking care of patients. I've literally been putting in spinal cord stimulators for about 30 years. And we'll talk about this in a minute, but when they first came out, they were about the size of a hockey puck. If you think about cell phones and what cell phones were like 30 years ago, remember you had a big like suitcase, you had to carry it around with a big thing, and think of what cell phones are like now. Spinal cord stimulation has had the same revolution in terms of what it's able to do for you, its effectiveness, and also its size. So we're not putting a hockey puck into people anymore. So in talking about radiofrequency ablation, it's a minimally invasive outpatient procedure. That's where they burn the tiny, tiny nerves. It can help pain in many different areas. Typically, that's not a procedure I do. That's typically a procedure that a pain specialist does. But let's say you come to me and we sort things out and we realize, oh yeah, this is the thing for you, then we can send you to somebody who does that. It can be very helpful if medication and steroid injections have not helped the pain, and they do a block. They try to block the nerves first before burning them to see if it helps. Then we know then that's likely to be something that can help. And it also can be repeated over time, because sometimes what happens is these tiny, tiny nerves that go to the joints, they can sometimes grow back. Now, let's talk about spinal cord stimulation, which is also a very, very exciting area for patients and taking care of patients. It's exciting for me as a provider because this really affords us ways to help people that we might not have helped, and things have gotten so much better now that even people that maybe with spinal cord stimulation the way it was 30 years ago, we couldn't help much, but now we can. So who are the people that might be benefited by spinal cord stimulation? Well, there's a thing called neuropathic pain. If there's problems, that's pain that's generated by the nerves themselves. So for instance, things like diabetes or problems with your circulation can cause neuropathy. You may have heard that word before. So that's a pain that's generated by the nerves themselves due to some problem with the nerves themselves. Perhaps you've had surgery. We've had people who have had surgeries that they've just come away with persistent pain, and that more surgeries may not be the solution. Spinal cord stimulation can help a lot of those folks. If you've been treated for chronic pain by a pain specialist for over 6 months and you don't seem to be making progress, or you're requiring more and more narcotics, spinal cord stimulation could be a help for you. If the pain is in your back, your feet, your legs, that can be a help. We talked about neuropathy. Sometimes people have a result of a damage to nerves from an injury that can give them what we call complex regional pain syndrome, or used to be known as RSD. That can be helped sometimes. And then if you're taking medication and it's not doing the job, then sometimes spinal cord stimulation can be a help to bridge that gap. All right. Plus, as we were talking about before, if you've tried all the things that I've already talked about, if you've already tried physical therapy, epidural steroid injections, and the radiofrequency ablation, then spinal cord stimulator can be an option for you. So what is it? Well, you've probably seen people with pacemakers that have the little battery here on their collarbone. It's a similar process, but instead of stimulating the heart, what it is we have these small, and depending on what reason we're putting one in, These are very small. If you're the older folks out there that know what about the size of a Zippo lighter, they're fairly small, and they sit underneath the skin, usually on your back. And then we have electrodes that go underneath against the spine. That, in a nutshell, is what these are. The principle is that they drown out the pain information. So pain signals that are, say, coming from your back or coming from your legs, then the electrical stimulation from this spinal cord stimulator drowns that pain out. Now, they're covered by Medicare and most insurance. They're reversible if they're not working or they seem to be having issues. Then we can take them out. So it's been a dramatic improvement for people in terms of treating chronic pain. So how it works, I think we've mentioned this briefly, and there's a little there's a little thing here that's not working. But basically, what it does is if your nerves are giving you the pain signals here, then we have it's the battery, and it's also a computer chip that runs the stimulation. The stimulation can be varied, and see, that's a thing that's been a great advance, is that there are ways now, we've figured out ways of stimulating of how often we're sending the electrical impulses and how strong they are, that can really help override the pain signal. So basically what they do then is the pain information is coming up here, then the stimulator blocks those out so that then they don't get up to the brain. So you literally do not perceive the pain information. Now, how we do it first is we do a trial. So that's one of the advantages of a spinal cord stimulator, is we don't even put one in unless we're sure it's going to help you. And so we do what's called a trial first. So we put a temporary one in. This is with small electrodes. They're small, maybe about 1 millimeter, about this wide. They're long things that we numb up the area and use needles, and we slide these into the area against your spine. And then that comes out through the skin. We put a bandage there, and you walk around with one of these for a couple days and see how it does. And what I tell my patients is, what you want to do is, number one, see what your pain score is. If you were running, say, a back pain of 10 out of 10 or leg pain of a 7 out of a 10, does the pain with the stimulation get it down to a 0? Does it get it down to a 5? If you have a pain of 10 and it only gets you down to a 9, well, then we're probably not going to be able to help you with this. But let's say you have pain of a 10 and it gets down to a 5. Well, then, that's something that is helpful, right? If you can reduce your pain by half, and that's really what we're looking for. At least we want to get the pain down by at least half, because nobody wants an operation that's only going to help you a tiny bit, right? And that's the thing. If you only get a 10% improvement in your pain with the stimulation, well, then it's probably not the best thing for you. Patients who are able to get back to their activities, that's the other thing I ask people to look about, is look at your pain score. But also, I've had patients, I had a lady tell me not long ago, we did the trial, and she goes, this is the first time in 2 years that I was able to go shopping. And so those are the things we're looking for. Does the trial, during the trial, are you able to start doing the things you used to do before? Also, another thing that we often find is people are able to start decreasing their medication during the trial. I say, I did not need, I've got pain pills in case I need them. I didn't need to take them during the trial. And so that's another thing we look for, is that are you decreasing your need for narcotics? Because that's our goal, right? Also, people note that if they sleep better, and again, this is a thing I've had patients say, I was able to sleep because my pain was not waking me up in the middle of the night. So these are all the things we judge by to see whether a trial is effective. So, and before we go to that, if your trial, you come back to us and you say, you've met these criteria that we think it's going to help, then what we do is we take you back to the operating room, and the first procedure is an outpatient procedure. The second procedure is also an outpatient procedure. The second procedure we do in the operating room as we do the first procedure. And what we'll do then is that we just put you to sleep for the second one, because we know where the electrode needs to go. We put in a little bit bigger electrode just so that it has less chance of moving around. That runs underneath your skin to the battery. We make a small pocket on the back above your hip bone on your back, so that it doesn't hit against a chair or anything like that while you're sitting. And then you go home right afterwards. So having said that, I've done enough talking. Really, we felt that one of the best things that people, for instance, who are having surgery benefit from is talking to somebody who's had it. And so frequently with certain types of surgery, for instance, or spinal cord stimulation, we have a number of patients who are willing to talk about their experience, because I can blah, blah, blah here all night. But really what's helpful is to hear from somebody who's had it done, to hear what their experience is. And so let me, without further ado, I'm going to go on to, I'd like you to meet Wanda Huff. And she is a patient who's actually got a foot in both camps, since we've done a surgery on her neck, an actual structural surgery on her neck, but we've also had has a spinal cord stimulator for back pain and leg pain. So Wanda, I want to thank you again for showing up and helping us out here, and helping our patients who are out there, or the folks who are watching at home about this. If you don't mind, Wanda, can you tell us a little bit about your pain story? Tell how things went.
Sure. I've had 2 back surgeries, which did not work. And I swore off back surgery for years. So I was in a lot of pain until I met Dr. Govil. Dr. Govil helped me. He gave me pain medication. None of it worked. And then they referred me down to Dr. Miller's office. And I kept finding myself falling a lot. My speech went crazy. And I was really, I think the first time I seen Dr. Miller, I don't know if I walked in or if I had to be put in a wheelchair and come in. But anyway, they had done he wanted to do an MRI of my neck and my back. So whenever he did that, he found that I had something wrong with the disc in my neck, which I wasn't having any pain from that. It's just all the speech, the fact that I kept falling all the time. And he did surgery on that, and I'm telling you, that was great. I don't fall anymore. I actually don't have any kind of pain anymore. Now, before we did the back stimulator, he did the surgery on my neck too. So the back stimulator has helped me tremendously. I've come off all of the narcotic medications. I'm not even taking anything now, basically, except for maybe ibuprofen for a headache, or if it's a migraine or tension, Excedrin. But that's the most that I take now. And my life has really, really changed from what it was before. It has changed for the better. And to be honest with you, nobody else will ever touch my back but Dr. Miller.
Oh, thanks, Wanda. That's kind. Thanks.
So that's me in a nutshell.
Well, and Wanda points out a couple of things, is that before we consider surgery, we want to check your spine to make sure there are no structural problems that we could perhaps fix, right? Because if there's a problem, and Wanda had some compression of her spinal cord in the neck, and the thing is that we don't want to mask pain or mask symptoms if there's a problem that needs to be treated. And so in the process of after we first met her, she was like, well, wait a minute, why are we looking at my neck? And I said, well, because when we examine you, I see that you've got some issues there that might explain why you're falling. And sure enough, she had an issue. So before she was sent to me to put a spinal cord stimulator, and she'd already had a trial, but then we got this test to be sure, and sure enough, she had an issue. So we did a traditional, minimally invasive approach surgery on her neck first, because it wouldn't have been safe to put a spinal cord stimulator in her, and then we subsequently put the spinal cord stimulator in. Can you tell us a little bit about your surgery and what it was like for you?
Wow. The surgery was great. You guys were awesome. The team was awesome. After I had the stimulator put into my back, I don't know what else to say except for it's wonderful. I feel no pain. I'm not in no pain. I can do things that I've always wanted to do, like go on a hike, just little bitty things like I can wash my own clothes now without my husband's help. There's a lot of things that you don't realize that you miss until you're down and out and you can't get it done. Because my husband has done everything for me from the time that my back went slap out on me until I seen Dr. Miller. And when Dr. Miller came along, he really and truly changed my life for the better.
Well, thanks.
So,
Glad we were able to help you.
You're welcome. So if you have any questions or anything about it, call his office. And he will put you with the right people. If he can't do anything, maybe Dr. Goebel can help you. And the stimulator, really, from the get-go, I was on the trial with the stimulator in the beginning. And whenever you're in pain for so long, you really do enjoy being out of it. And it really helped a lot. And that's why I did the stimulator, is because that it has changed my life for the better. I do things now I never used to do.
Well, that's awesome.
So,
Now,
thank you very much.
You are so welcome. I mean, we've just been so glad to help you. So you're just a wonderful person, and we're just happy we've been able to turn things around. And that is one of the advantages of the spinal cord stimulators, is when they work, they do a great job for people. They can really help people. Now, one thing I wanted to mention is that the battery that is a rechargeable battery. And so what happens is we put this battery in, and most patients, we do have some that are don't need to be recharged, but they don't last as long. But the batteries we put in that are rechargeable last at least 5 years and sometimes more. And you have to recharge it. And if you wouldn't mind, Wanda, can you just, because a lot of people are curious about this, you don't have to plug yourself into an outlet like a Tesla car or something like that, but can you kind of just let them know, talk to the folks out there about what the daily life with this thing is like?
Okay, my daily life with the stimulator is every morning I get up and I'll think about it, because I quilt, I love to sew. It's like a hockey puck. So I have a strap that I put around me, and it's on the battery. And once it's charged, it stays charged for at least all day. And then again, you want to charge it again the next day, because trust me, you do not want that thing to get down to no numbers at all. So it took me to get everything going right. I think it took me about 3 days to get that little hell hand thing going, to where I do it maybe 30 minutes a day now.
Mm-hmm.
And that's about it.
Yeah. So what Wanda is describing is there's a little charger that you can put against your skin that charges the battery, and then there's a belt made for it with a little pocket for the charger that you can wear around you, so you can go about your whatever you want to do,
Yeah.
some laundry or whatever, walk around, watch TV while it's charging. So it's like there's not a charging station. You don't have to plug yourself into a wall with this. So that's an advantage. and I know you talked about how it's changed your life. For the people who are out there right now listening, what would you have? What words would you leave them with? What would you have to say to them about this?
I would say to them that if they have had no success at all about being out of pain, because I come off the fentanyl patch, I come off morphine, and it's really a great thing to do if it's for you. Now, everybody it may not be for, but like I said, Dr. Goebel and Dr. Miller has taken care of me, and they have been there for me. And I appreciate them so much till they just don't know what they have done for me in my life. If you have pain and you're in pain and you can't get out of pain, please go see Dr. Goebel. If he can help you, he will. If he can't, I feel like he would send you down to Dr. Miller's office, would be the next thing that he would do. And then Dr. Miller will take good care of you. He really will. He won't do something unless it's absolutely necessary to do. And I have learned that. He cares about his patients. And I think that, if it's for you, do it. If you're not any better and you've been taking these high-priced drugs and you just can't seem to function, call Dr. Miller's office. Talk to Dr. Goebel if you're seeing him for pain, and they will hook you up.
Yeah, I should mention, I don't know if we mentioned this, Dr. Goville is a local pain specialist. So he's also here at our hospital, and he does, for instance, the radiofrequency ablations, he does the injections, and he's a pain specialist. So we work hand in hand for taking care of patients with chronic pain. All right, Lee, do you have anything at this point? Shall we open things to questions?
So Dr. Miller, go to the next slide.
Yep. This
Can you
is
hear me
how,
okay?
yeah, this is everyone, if you can see this, these are our information about, we have 3 offices. We have an office, the main office here, the NeuroSpine Center here in Statesville, and then we have an office in Mooresville, and we also have an office in Hickory. And you can see there the websites and to go to about more information about us or about the pain treatment, and our number there for a referral. I will say this is that for those folks of you out there who are watching right now, we don't require a referral, but it's helpful for us. We do need to get your records from like your family doctor, so we know what kind of medical problems and what's been done so far. So all you need to do is call and say, look, I watched the webinar, and I'm interested in having Dr. Miller and his team take a look at things, and so we can get things set up for you.
So
Yeah.
I think the next slide,
Yeah.
for questions, for those of you that are on the webinar, there's a few ways to ask questions. Again, you can type a question into the Q&A feature, or you can text me and I will type in the question or read it out loud. And that number is 336-215-2055, 336-215-2055. Or again, you can type in a question into the Q&A section. So while we're waiting for questions, I'm going to actually ask the audience to answer a few questions on the screen. So a few things we would love to know from you. Did you find this webinar valuable and informative? And if you're interested in a consult to discuss one of the treatment options, please let us know. And then also we'd like to know how you found out about the webinar. So while you're thinking of questions, you can take some time and vote. So let's see. Dr. Miller, we have a question. My back pain has never been diagnosed. Is it a disc issue, arthritis, or muscle spasms?
So it's hard to know, right? If you have long-standing back pain that either comes and goes a lot or it's with you constantly, then that's a thing that's a reason why you need to be seen by somebody. And we're certainly, we can certainly see you. And probably the first step would be to get an MRI of your back and see what's going on. Because really, it's hard to know just based on symptoms exactly what's going on. And so, we're happy to see somebody with pain like you're having, and then we can evaluate it, see what the problem is, and get some pictures, and then get an MRI, for instance, and then we'll know what we would need to do next.
So the next question is, I'm not a surgical candidate. I have had injections and pain medicine and nothing works. What should I do?
So then, depending on where your pain is, if it's back and leg pain, then those are things that oftentimes a spinal cord stimulator can help with. And again, hard to know, as long as there's no medical problems that might prevent you from having anesthesia safely, you may be a perfect person for having a spinal cord stimulator trial. Because remember, that's the beautiful thing about this technology is we don't put one in unless we're sure it's going to help you. So we don't just put one of these in and say, okay, let's see how it does. We do the trial first to see if it's going to help you. Because obviously we don't want to put something in you if it's not going to help. So you sound like you might be a person that could be exactly the type of person that can be helped with this.
The next question is, I have had 4 radiofrequency ablations. The first recommended by Dr. Miller. The first 3 worked great, but the last one not so much. Is the spinal cord stimulator an option for me? I had a new MRI yesterday and we'll have results on Friday. How permanent is the spinal cord stimulator?
Well, I mean, yeah, it sounds like you're doing all the right things. We'll see what's going on if there's any new changes or anything like that. But the one thing to know is that a spinal cord stimulator is not permanent. I mean, for instance, we sometimes have to take it out for whatever reasons, or if somebody says, look, it's not been working for me, or, there's other reasons that might need for taking it out. Yeah, absolutely. We can take it out. It doesn't take very long at all. It's not a thing that's in there forever. We can get it out if need be. The other thing I would want to mention just for everyone is that these batteries I mentioned last at least 5 years, but they do stop taking a charge very well after a while. When we have to replace it, that's literally a 10-minute operation. We do it over in the hospital in the operating room so that everything is sterile, but we just numb things up. You don't even have to be put to sleep. We take out the old battery. It literally takes me 10 minutes. It's actually faster to change one of these batteries than it is, say, like the battery in a lot of cars today, because you have to get in there and you know how engines are a little bit of a problem these days because they're so complicated. So no, it's actually a fairly straightforward procedure.
Next question, should I come in if I'm in acute pain in the acute pain stage, or is it okay to be staying when at stage 3? Is that?
Well, it depends. If you're successful in managing your back pain episode at home and things are calming down, then like as I said before, if it ain't broke, don't fix it. If you're doing better and you've gotten over it, well, then there's probably nothing you need to do. But let's say you have these frequently and it's starting to limit your life. You're having episodes of back pain that are limiting your life. Well, then, yeah, that's probably a time if it's a recurrent problem, then we probably would want to get an MRI to see what's going on. And then we would know, like, let's say it comes back, then we would know exactly what's going on and we could be jumping at it in terms of treating it quicker.
So I have an email question actually that I got today. How do I know what type of doctor I need to see for my back pain? And does Dr. Miller offer facet joint injections as a treatment option?
So let me answer the first part. I don't myself do facet injections or those kind of things, but like for instance, the doctor, there's a lot of Dr. Goville, or there's other doctors, pain doctors who do those kind of things, because you want to do those type of injections with a x-ray machine to make sure you get the injection to the proper area. As far as what kind of doctor, that's it's sometimes hard to know, right? And you can never go wrong by seeing your family doctor. If you're having back or leg pain or things like that, that's a fine start a lot of times, is to go to your primary care doctor, and they can sort things out. And then if they feel like, there's a problem, they can send them on to us. Certainly we can see people off the street with back pain, but the problem there is then we have to get an MRI and those kind of stuff. Sometimes if you go to your family doctor, that oftentimes is a good starting place.
So I did have one more question via email, but I think you answered it. Do you offer treatment options other than, the question was, other than epidurals and physical therapy, what could help with stenosis, spondylolisthesis, those kind of things?
Sure. And so yeah, there's a lot of things. Even patients who have spondylolisthesis, is slippage of the bones on one another. That's a very common problem. And in fact, if you imagine the vertebral bodies, the bones in your back are like soup cans stacked. Sometimes what happens is they start slipping on one another, and that can pinch the nerves. So yeah, there's a lot of things, even for serious problems like that, that we sometimes can get you managed without needing surgery. I would say a lot of times what happens is we start with the easy things first, and then move up the scale if they don't work. So like sometimes, non-narcotic medications, and then we go on and go up the scale from there at injections, those kind of things. And for whatever thing that you might need, for instance, an epidural steroid injection, well, I don't do those here in the office, but we would send you to a pain doctor who could get that done for you. So yeah, the short answer is, yeah, absolutely. There are plenty of options available depending on what the problem is.
Can you see this question on the screen, Dr. Miller? Or can you open your Q&A at all? If you can't, I'll read it.
Hang on a second. Okay, yeah, from Paige.
My father is, from Paige.
My father's 85 years old, yeah. Let me just read this for a second. So, and yeah, I guess, does everyone at home see this as well, or no?
I am not sure, to be honest with you.
Okay, let me just read it out. Hi, Dr. Miller. My father is 85 years old and had back surgery, parentheses, L2 and L3 laminectomies, L3-4 fusion in 2016. His pain was better after the surgery, although he had numbness in both legs and his feet after the surgery. The pain in his back returned about a year ago, and all his orthopedic surgeon has offered him is pain medication and physical therapy. Not only does the meloxicam have way too many bad possible side effects to even expect that to be any type of long-term treatment, but the PT is also only strengthening his core and not really assessing the root cause, which is that the L5-S1 is now compressing. Since he is 85, we are feeling surgery is not an option. So can you tell me what would help the nerves come back to life such that his numbness and his back pain go away? There must be something to treat the stenosis and scoliosis. His PT told us that he needed to be seeing a neurosurgeon instead of an orthopedic surgeon, although the one who did his surgery was pretty good as these things go. Thanks for any advice you might have. So I guess I would say, number one, it's hard for me to give any answers on a specific case just because I don't have the MRI in front of me and haven't seen the patient. But I would say in general, 85, although depending on how people are, we have sometimes actually done scoliosis surgery minimally invasively on the oldest patient we've done is, I think, 83. Now you have to be a pretty vigorous 83. However, most patients, as they get older and into that age group, we don't want to consider a big structural surgery on. And so, yeah, spinal cord stimulation can sometimes help, and it all depends on the causes. And so it's hard for me to know without seeing films and seeing exactly what we're up against, what's available. But I would say, your dad sounds like a person that would probably benefit from being evaluated by us. We'd be happy to see him and see what things are possible for us to help him.
All right. Does anyone else have any questions? I think that was our last one. Those were great questions, everybody. And
Yeah, absolutely.
again, it's hard to answer things so specifically without having records and films. So I would encourage you, like Dr. Miller said, call the office, see if you need a consult, and they may ask you to bring your records in, right, Dr. Miller?
Yeah, absolutely. And really that helps us know, number one, what surgeries you've had, know your general medical conditions. So, for instance, people who have cardiac issues or stuff, those are obviously all things we want to know in advance in preparing how to best take care of you.
So I think that I will end the polling unless anyone else feels like that they would like to vote or cast their answers here. Again, we love your feedback. Oh, wait, we have one more question.
Oh, thanks. You're welcome, Paige. Thank you.
Oh, yeah, thank you. She says thank you. Awesome. All right. Well, guys, that concludes the webinar. And Dr. Miller and our patient Wanda, thank you so much. I hope you guys found this beneficial. And you will get a follow-up message if you have further questions. You'll know how to get in touch with me or Dr. Miller's office. And I will, Dr. Miller, maybe advance back one more slide if they need your phone number.
You know what? It's not working right now. I don't know what, did we,
Nope. Click on it.
Oh, wait,
and there
got
we
it.
go. There we go.
Yeah.
So,
Okay.
or for some reason, yeah, the phone number up is in the top right-hand side, the 704-954-8277.
And that's the same office number you see. That's our general office number that gets you in touch for any of our 3 offices. There.
Yep, and then their website there as well. So thank you again, guys. This concludes our webinar, and I hope everyone has a great rest of your evening. Stay safe and healthy.
Thanks, everyone.
Thank you.
And thank you, Wanda. Thank you very much. And Lee, thanks.
Thank you.